From Microbe TV, this is Infectious Disease Puscast, episode 88, recorded on Monday, September 1st, 2025, Labor Day. Hello, everyone. I'm Dr. Daniel Griffin, and joining me today is Dr. Sara Dong.
Hey, everyone. It's Sara. Happy Labor Day. You done anything fun?
We're laboring on the day. I don't think you're supposed to do that.
Yeah, I've had a pretty uneventful Labor Day. We would just like house stuff. I bought a piece of furniture, and that's what I've been up to. What about you?
Well, I got up my usual time, nice and early, and before the sun rose, I was out with a buddy of mine doing that e-foiling that I like to do. And you know, I need to probably be honest with my age because my back hurts. So afterwards, I was like laying on the couch. If my wife could somehow help out with that, and then I went for a run because that's a good way to loosen up your back when you're in pain. And I'm gonna maybe someone has a heating pad or something to figure this all out.
We have some good articles today. We'll welcome everyone to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. Well, I will start us off with our viral section. I'm trying to figure out if this is going to end up making the This Week in Virology as well, but maybe people should listen. So remember to listen to This Week in Virology, both the clinical update as well as in the deep dive, the recent deep dive with Stanley Plotkin, which is great, by the way, better than mine. Just what a superstar, right? In sort of the history of vaccines. But I will start us off with the MMWR respiratory syncytial virus immunization coverage among infants through receipt of nirsevimab monoclonal antibody or maternal vaccination in the United States, October 2023 to March 2024. I think our listeners are pretty familiar. Respiratory syncytial virus, RSV, is the most common cause of hospitalization among U.S. infants. So we're thinking this is all going to be over, but in 2023, a long-acting monoclonal antibody for infants, nirsevimab, and a maternal vaccine were recommended to prevent RSV among infants. Here we have cross-sectional analysis of data from the Immunization Information Systems, IIS, right? And I'm pretty sure that's not Roman numeral. I'm going with Immunization Information Systems, unlike our inactivated influenza, which we couldn't sort out last time. So representing 33 states and the District of Columbia, found that I'm going to insert in only 29% of infants born during October 2023 to March 2024 were immunized against RSV through receipt of nirsevimab or through maternal RSV vaccination during pregnancy in the 2023-24 respiratory virus season, the first season that these products were available. State-specific immunization coverage for nirsevimab or maternal vaccination ranged from a low of 11% to a high of 53%. And I put on my glasses to go through this figure a little bit with folks. But you can actually see that there were some hotspots. There were some places, like I'm headed up to Maine on Friday. They did a great job, greater than 40%. Recording down here in New York, not so good. Looks like less than 20 if I can read these colors. So not so great, fellow New Yorkers, right? What do you think? Is that 20 to 30 or you think it's less than 20? I'm trying to, the colors are just
decide which blue it was.
Yeah, I'm thinking maybe it's 20 to 30. Yeah, still not to impress New York. I guess better we go to B, and then I can find New York here. Down near the bottom, less than half, right? So we've got Vermont going strong, where the majority of the kids were immunized, but only the majority, only about 50-something percent. Florida, Nevada, Mississippi, you're not doing great. So here we have really the ability to prevent the most common cause of hospitalization in U.S. infants. Incredibly safe, effective tools. We really got to start using them. Hopefully it was just the first year. There were some issues with education and access and supply. Really hoping we do better this time around.
And for me, I think I might have only brought one viral paper today, but I brought a HIV paper. This is from the Lancet HIV. Bictegravir, emtricitabine, and tenofovir alafenamide versus ritonavir-boosted protease inhibitor-based antiretroviral therapy in people with HIV, and viral suppression on second-line therapy in Haiti, an open-label randomized non-inferiority trial. So as you heard from the title, this trial was conducted in Port-au-Prince, Haiti. They took adults with viral suppression on second-line regimens, so ritonavir-boosted protease inhibitors plus 2 NRTIs, and they randomized them to switch to Biktarvy or to continue their current regimen. So the primary endpoint was HIV viral load less than 200 at week 48. The pre-specified non-inferiority margin was 4%. They had 301 patients, so 153 assigned to the Bictegravir group and 148 to the boosted PI group. Enrollment was stopped early due to restricted access to the protease inhibitor-based regimen. But at week 48, the patients with undetectable viral load, the comparison was 0.7% or 1 out of the 153 patients in the Bictegravir group versus 4.1% or 6 out of 148 in the boosted PI group. That was the difference in patients who were not suppressed. And so they also took a look at the proviral DNA genotyping to look at baseline resistance in participants switching to these NC-based regimens. So they did find a high proportion of patients had NRTI resistance at enrollment. For example, about half of patients had a M184V mutation. I didn't write all the mutations here, but you can see more info about that in the paper. But despite that, you only had that basically one patient, less than 1%, who had virologic rebound, and no one in either group developed emergent mutations on any ART med when they looked at it in this group. And so there has been a prior study to SD that also had similar findings, but instead of Bictegravir, it was dolutegravir at the time, but didn't have this sort of proviral DNA portion. So to summarize this, if you had a patient with HIV who's been virologically suppressed and has possible or confirmed NRTI resistance, this study would suggest that you could switch to a simple treatment of once daily Bictegravir, emtricitabine, TAF, away from their boosted PI regimen. So I'll try to bring more HIV. I feel like I should incorporate it more, even though I usually shy away from bringing those papers on Puscast. But this actually kind of related to something I was looking up for a patient of mine. So I thought I would add it to the list today.
Yeah, now I have to say Biktarvy has really turned into the workhorse, right, of our HIV. I think I joked on a prior podcast, I refer to the HIV patients as those on Biktarvy and the others, right? It's really become the most used regimen here in the U.S. Really nice, simple, well-tolerated. All right, we've got the article, Interferon Alpha Nasal Spray Prophylaxis Reduces COVID-19 in Cancer Patients, a randomized, double-blinded, placebo-controlled trial published in CID. So these are results of a multi-center, randomized, double-blinded, placebo-controlled trial, which participants were randomized 1-to-1 to either spray up their nose once a day, 40,000 IUs of interferon alpha, or a saline placebo. Participants who developed influenza-like symptoms self-collected nasal swabs for PCR testing, SARS-CoV-2, influenza AB, RSV, paraflu, adenovirus, seasonal coronavirus, picornavirus, human metapneumovirus, and or the SARS-CoV-2 rapid antigen testing. They had co-primary endpoints, incidence of COVID-19 and or other respiratory viruses, less than 90 days of randomization. So we've got 433 participants randomized. So we've got 217 spraying the interferon alpha. We've got 216 in the saline placebo. the incidence of COVID-19 was lower in the interferon alpha group versus placebo. So that was pretty impressive, 8.3 versus 14.4. So a 40% reduced risk of infection, a relative risk 0.60. Good confidence intervals. Now, other respiratory viral infection incidence was really pretty much the same, really not seeing much of a difference there. I was surprised. I was like thinking, okay, well, this is great, but why just COVID-19? So I will say no differences as far as how folks did overall, no difference by underlying malignancies, no differences as far as secondary endpoints, severity, hospitalization, mortality. But the interferon alpha was well tolerated. It was safe. They did some subgroups trying to figure out, if you look at particular subgroups, so less than 65, you actually had relative risk 0.48, female sex relative risk 0.44, COVID-19 vaccinated, relative risk 0.5, and a really nice plot probability of COVID-19, your Kaplan-Meier curve there. All right, so I'm just not sure. Are we going to start spraying this stuff up people's noses? Is it ready for prime time? We'll see what comes next. All right, bacterial. Be sure to listen to This Week in Microbiology, the article Exposure to Suppressive Antibiotic Therapy in Women with Recurrent Urinary Tract Infections and Severity of Infections, a retrospective population-based cohort study published in BMJ Open. Now, I have to say, when I saw this, I was very interested, intrigued. What are we going to find out here? Some of us probably are aware that women with recurrent urinary tract infections often undergo intensive antibiotic exposure, and especially with suppressive therapies, right? So a lot of antibiotics in this context. And we've talked about some recent guidance. Suppressive therapy is recommended for women with 3 UTIs in the past year or 2 in the last 6 months. So we end up with this study. It's conducted using data from the Information System for Research in Primary Care database, 5.8 million people in Catalonia, 2 groups of women with recurrent UTIs, that's greater than or equal to 3 episodes per year, and they're going to compare them. So we've got those on suppressive antibiotic therapy for 6 months or more, and then folks that are just being treated episodically. Primary outcomes were hospitalizations due to pyelonephritis, septicemia, COVID-19, influenza, pneumonia, and mortality by these infections over a 100-month follow-up period. Still trying to figure out why COVID-19, flu, and pneumonia got thrown in there, but who knows? Among 36,170 women, only 8% were treated with continuous suppressive therapy. Overall, 6.9% of the population experienced severe infections, with a higher incidence of severe infections in women on suppressive therapy, 12.6% compared to those without, 6.4. So hazard ratio of 1.5. Pyelonephritis presented the greatest difference, hazard ratio 1.95, followed by septicemia, and COVID-19, which I still don't quite understand. So I'm trying to figure out if this is causal, coincidental. What are your thoughts? How could being on continuous suppressive antibiotics increase your risk of COVID-19? I don't know, microbiome disruption or something?
Yeah, I'm not sure. I'm sorry. I'm trying to wrap my head around what they did. Yeah, you're right. How COVID ended up in there.
Yeah, it's a little
I guess
strange.
they're trying to assess severity of infections in general and use COVID as a marker.
But it does seem interesting, right? So you've got, so here's this recommendation: put people with their current UTIs, put them on antibiotics. It's going to reduce your risk of recurrences. But when you do have a recurrence, it looks like it's going to be severe, right? So you're actually, you're minimizing the times that they might end up, with a UTI that requires episodic treatment. But they may end up, septic or having severe infections. So kind of making me kind of rethink what's going on here. But I'm trying to figure out, was there something up with this study? Because I'm not sure this coincides with what I'm seeing in clinical practice, right?
Yeah. Well, I actually picked another kind of, I guess I'll say UTI adjacent, for mine. This paper was from OFID, Effectiveness and Safety of Antibiotics in Kidney Transplant Recipients with Asymptomatic Bacteriuria, a Systematic Review and Meta-Analysis of Randomized Controlled Trials. So I will just summarize the tagline. Current state of the art evidence does not support routine screening and treatment of post-transplant bacteria in kidney transplant recipients. So I think many people who listen to podcasts already know this or are familiar with their center's approach, but asymptomatic bacteriuria is/was often screened and treated in kidney transplant patients with the hope that you eradicate the asymptomatic bacteriuria, that you reduce their risk of acute pyelo or sort of symptomatic complicated UTI. But as many, I would say in particular, transplant ID physicians are aware, there's been data arguing against this and suggesting that antibiotics do not reduce subsequent symptomatic UTIs or provide benefit as far as graft outcomes, and sort of worst case may select more for resistant organisms. And so the authors here included those couple trials that are out there. So there were 4 in total, comparing antibiotics versus no therapy in kidney transplant recipients with asymptomatic bacteriuria. So you can see the kind of more detailed breakdown in table 1. But pooling all that together, there was 478 participants or patients. Antibiotic treatment and kidney transplant recipients in this setting, asymptomatic bacteria did not have a protective effect. They couldn't answer as much. It's kind of a little bit less certain the impact of antibiotics on things like multi-drug resistance and C. diff and some of those sort of secondary things that we think about. I think the gap or question that we still have in particular is the impact of antibiotics for asymptomatic bacteria within the first 1 to 2 months after transplant. So this is the window where patients are more profoundly immunocompromised. They often have their ureteral stent or an indwelling catheter, so that can facilitate bacteria getting to the graft. And so those patients were excluded from these trials. And so for me personally, that's a window of time where I'm more lax about how forceful I am saying we shouldn't give antibiotics, we shouldn't be screening. But as a rule, I want to reinforce not treating asymptomatic bacteria even in kidney transplant recipients. I think people know that in ID, but I've found that you still need a little bit of education sometimes, because maybe that is not a concept that people are used to, or perhaps they've been practicing somewhere where there's still a lot of frequent UA urine culture screening and treatment in response to that. So if folks want, it's a nice sort of summary instead of having to, if you don't have the papers saved on your computer like I do, you can save this one and refer to all the trials at once.
Yeah, but no, it's also nice, just even the opening line is current state-of-the-art evidence does not support this as an indication for treatment of asymptomatic bacteria. And I'm not sure this study changes the state-of-the-art evidence. So. All right, the article, Epidemiological, Temporal, and Geographic Trends of Leptospirosis in the United States, 2014 to 2020, published in PLOS NTDs. In 2014, leptospirosis was reinstated as a nationally notifiable condition due to evidence of increasing incidence and public health importance. Between 2014 and 2020, CDC received over 1,053 case reports from 34 jurisdictions. The national incidence rate was 0.48 per 100,000. Since 2014, leptospirosis cases have been increasing with an average annual gain of 13 cases. Cases increased in summer, peaking in early fall, corresponding with warmer weather, and hurricane season. Among cases with outcome data, I was really surprised, but it's 85% were hospitalized, 10% died. I'm kind of wondering how many were missing. 77% of cases reported contact with animals or their bodily fluids. Okay. Well, 71% of cases reported contact with fresh water or mud. More cases reported avocational activities as a source of their animal or environmental exposures, as opposed to recreational or occupational activities. Only 13% of cases reported any international travel in the 30 days prior to symptom onset. And we've got a nice map where you can see, Guam, Puerto Rico, Hawaii, the Virgin Islands, apparently District of Columbia, New York City are hotspots for leptospirosis. I understand New York City. The rats have leptospirosis. We actually have it. There's not far away, a park where we're not allowed to walk dogs, but we do anyway. And there's maybe some leptospirosis in the creek there. So a friend of ours, their dog Millie almost died of leptospirosis. Ended up in the dog hospital. So I think we're missing cases. I think there's even more cases than we're aware of.
I've been looking for it. I still haven't diagnosed it, but one day I'm going to look for it and it'll actually be what
and you'll find
the answer is. Yeah. This next paper I pulled was from OFID, performance of tongue swabs for tuberculosis diagnosis in hospitalized children under 5 years of age. This was a masked prospective observational study in 2 South African hospitals. They took the expert MTB-RIF ultra testing. So these are tongue swabs collected from children under the age of 5 deemed high risk for TB. And so those children were characterized as confirmed, unconfirmed, or unlikely TB. So of the 201 patients enrolled, 5.5% had confirmed TB, 26.4% were categorized as unconfirmed, and then 68.2% in the unlikely TB bucket. So the testing, TS-XU, I'm just going to say tongue swab testing reported MTB detected in 57.7% of the 200-ish patients under 5. Those results, when you broke them down, is they had trace, which is one of the options, was 77%, very low, which was 18%, low, medium, which was 4, and 1, respectively, for low and medium. There were no high results, which is another result that you could get. So they, if you presumed that the trace results were negative, the sensitivity was 17%, specificity 89%, and it detected MTB in 15 or 10.9% of 137 children in that unlikely TB bucket. So they talk a bit about these trace results, which are a little bit challenging to interpret. But overall in this study, they were able to detect more cases in children under 2, and that they also kind of talked about how this testing could facilitate collection of other novel testing because it increased the number of confirmed cases. And so in their study, right, that would be an additional 15 of the 137, that's where that 10.9% is, of children with TB that were confirmed under 5 that were considered unlikely TB. And then it changed the overall number of children under 5 receiving TB treatment by about a fifth, so 78 to 93 out of 201. So for those trace results, in adults, that trace tongue swab result could be a reflection of previously treated TB, but that's going to be relatively rare in these young children. So only 1.5% were in that, would have fallen into that previously treated TB sort of description. And so even though you could interpret a trace result as asymptomatic or early stage disease that was potentially missed, there's also an issue of sample cross-contamination. And so there's air swab control. So 1 out of 8 air swab controls in the study reflected contamination in the sort of health facility air spaces in general with MTB. But sort of the take home is that the sensitivity of this testing was similar to routine gastric aspirate testing. So I pulled this. I just think it's really cool to see a novel assay testing that's actually performed in children and not just extrapolating from adults. And I think anything that we can do to help diagnose these younger children would be helpful because it's, very challenging and sort of doing your best with the options available to try to get that diagnosis. So very cool.
Yeah, and I think this is a challenging area. You're not going to really get good sputum from kids under 5. And then, unfortunately, even looking, comparing to the gastric aspirate that we always talk about, not great sensitivity there. So, and that's quite something, right? Doing that first AM gastric aspirate on a little child. If you can get similar sensitivity by just swabbing their tongue, this is seems like a good move forward.
All right. And I would take us into our fungal section. We don't really have anything to endorse. We have mentioned Last of Us. But I was pretty excited by the one paper that I pulled. This one's from Lancet ID, towards shorter therapy for candidemia, defining uncomplicated candidemia in adults. This was in the Lancet, so they spelled their candidemia with the extra A.
Yes, I noticed that.
So pretend I'm pronouncing it with the extra A. So this was a review in which authors were trying to define uncomplicated candidemia, or at least try to start to think about how we can differentiate them from our more common sort of complicated cases, the ones that we say you're going to get 14 days at least of therapy. As they looked at patient characteristics, mycological criteria, antifungal treatment and management strategies, and the impact on outcome of candidemia after screening about 5,000 plus articles. And so they ended up sort of drilling down on 5 publications to use to form these criteria. So the authors here proposed uncomplicated candidemia can be defined as candida clearance in the blood with documented appropriate source control and clinical response within 5 days of antifungal treatment. There is more detail in a panel on page 3 in the paper, and some of that comparison can be in figure 1, which is very nice. So figure 1 sort of takes the characteristics and has this nice like red and green color coded complicated versus uncomplicated. So the things that you would think of in complicated anyways is kind of confirmed here. Prolonged bloodstream infection, anyone who's immunosuppressed, they put in a different, this complicated side. Patients with IV drug use, extra-abdominal organ candidiasis, echinocandin-resistant species, or, of course, a recurrent infection. And I should just say, I'm sure everyone already knew, this didn't include pediatrics at all. So this is just in adult patients. But the other figure that I thought was nice is figure 2. They did this timeline depicting sort of onset of candidemia and some of the criteria, and sort of they made this line going from the green versus red for uncomplicated to complicated. So you can read more about the breakdown of each of these features that they pull out. But, this is not a trial. It's not new data that tells us we can jump to trimming antifungals to a shorter duration right now. But they're proposing this as a way to hopefully, start considering what might be complicated or uncomplicated, where in the future in clinical practice, we might use shorter durations, but hopefully inform future trial evaluations that actually look at this question in more detail. So I think quite interesting. It's hard. We don't typically think, it's hard to pull out who would be that uncomplicated scenario. So this is, I thought, interesting.
Yeah, I feel like they're using the Staph aureus paradigm here.
Mm-hmm.
But I await the future trials, because it's like which ID doc has found an uncomplicated Staph aureus bacteremia that only needs 2 weeks of therapy, right? I mean,
yeah. All right, and then I will move us into parasitic. Be sure to listen to This Week in Parasitism. Anything on the coming up that you're excited about, Daniel?
So we've got some good ones. We've got a guest coming up, so we're about to do our unveil. We pushed the recording a little bit forward just because I think Vincent was a little tardy in dropping the episode. Give people some time to get those guesses in. Then we're also gonna talk about that ivermectin malaria paper.
Nice.
So a little dive deeper into that. Yeah, exciting stuff coming up there.
Cool. I picked a relatively quick one. This one is also from OFID. Outcomes of military blood donors at Joint Base San Antonio with reactive Trypanosoma cruzi antibody screening. So military blood donors are screened for T. cruzi antibodies with every donation. And reactive antibodies are a reason for deferral, so not being able to donate more. But I think what happened after that, the follow-up was unclear. So the authors here took a closer look at that. So they reviewed medical records of all about, scanned through these 89-ish thousand blood donors at this specific Armed Services Blood Center at Joint Base San Antonio, Lackland, with reactive screening for T. cruzii. This base is an area shown to have vector infection rates over 60%, and there's been a prior seroprevalence study of dogs on that base that had an 8% infection rate. So just to set the stage, we've kind of talked about it occasionally on Puscast, these areas where it seems like T. cruzii is in the vectors, but what is that? What are the implications for our patients? In this case, it's blood donation. So 49 or 0.055% screened reactive of the big number I told you. Of those, 4 or 8% had a positive test, and 18 or 36% had indeterminate supplementary test. None of the donors met criteria for Chagas disease on clinical diagnostic testing. Of the 8 who had repeat testing ordered afterwards, only 1 had a repeat reactive screening test, but subsequently had a negative confirmatory screen. So basically no confirmed cases. And so they talk a bit in the discussion about the impact of the screening on sort of the trainee in most cases, if they're coming for training and sort of being pulled away until this gets dealt with. But that there's also not really a path for these prospective donors to re-enter the donor pool, even when, it's been clarified that there's no concern. So, a smallish number, but just something that I thought was a way. These military studies are nice because we don't often get these sort of insight into a collection of folks and what happens for testing like this. So just something to think about. And hopefully they'll be able to figure out a way to get those folks plugged back in so that if they were able to donate in the future.
All right. Well, the article Cutaneous and acanthamoebiasis, 2 cases highlighting diverse histopathologic findings, published in the Journal of Cutaneous Pathology. I don't know if that's on your list there.
Table of contents email.
But our listeners might be familiar with this organism, infecting the eyes, and people using contact lenses, and maybe people are familiar with the amoebic encephalitis. But here's a couple of cases of cutaneous amoebic disease. So, case 1, 23-year-old hospitalized patient with lupus and pancytopenia acutely develops these nodules on the extremities. I've got some pictures. Biopsy showed this lymphohistocytic inflammation, focal coagulative necrosis in the subcutaneous fat, and the trophozoites and cysts were apparent on H&E stain sections. Actually, even better if you look at the silver stains. PCR studies positive for acanthamoeba species. Case 2, 81-year-old with diffuse large B-cell lymphoma on Indelalicib. Am I pronouncing that right?
We've learned. Say it confidently.
Yeah. Indelalicib. So basically that's an IBS, right? Small molecule inhibitor. Presents with a 3-week history of ulcerating nodules on the extremities. Biopsy from the left arm exhibited a mixed deep dermal infiltrate with neutrophils and histiocytes. Biopsy from the right arm exhibited granulomatous inflammation. And yes, the trophozoites and cysts were apparent in H&E and PS stain sections. So we have some nice figures. This is, fortunately behind a paywall. Sorry about that. But if you can get through the paywall, we've got these really nice figures. And, the classic, the author suggests that cutaneous acanthamoebiasis should be considered in biopsies of cutaneous nodules from immunocompromised patients. The histopathological inflammatory changes are variable, nonspecific, while the organisms are easily overlooked due to their resemblance to histiocytes. So I just think basically we need really good pathologists to pick these up. Because once they hone in and there's that black arrow, I mean, how are you going to miss it?
But it's true. I don't think about acanthamoeba for causing a cutaneous nodule. Also, the pictures are very pretty.
Yeah. And I'm not suddenly going to like every pathology report, and by the way, don't forget to like. So, all right. Well, I'm going to close this out. We have a couple miscellaneous, and this just sort of happened. I didn't plan this, but the first article This is the first one I popped in. Linezolid-related optic nerve disorders. Insight from a pharmacovigilance analysis of the U.S. FDA adverse event reporting system published in OFID. So people may not be aware of this issue, and so I thought it raised some awareness. So we're looking at 15,350,730 reports retrieved from the FDA Event Reporting System, FAERS database, from which signals defined as ROR greater than 1 were detected only for linezolid consistent with sensitivity analysis. So compared with other linezolid-related adverse events, linezolid-related optic nerve disorders were characterized by younger age, so less than 60, adjusted odds ratio of 6.86, and high cumulative doses. And that was really the big one. That was an odds ratio of almost 8. So they concluded that among this class of drugs, among the oxazolidinones, a signal for optic nerve disorders was detected exclusively for linezolid, but not for tedazolid. But we're in really a lot of tedazolid use. So just by the way, clinicians should ensure regular eye monitoring during, I'm really going to say particularly younger patients, high cumulative doses. And they got one of those nice graphical abstracts where you can see when things start to develop. All right, and I am going to close this out with the last one. And again, linezolid. The article is Extreme Variability in Linezolid Concentrations in the ICU, a case for routine therapeutic drug monitoring, published in the American Journal of Health System Pharmacy. So this is a case description, right? So in this article, they describe a 66-year-old ICU patient treated with linezolid for vancomycin-resistant Enterococcus faecium, peritonitis, and empyema. And we read that despite standard dosing, so 600 milligrams IV every 12 hours, the linezolid concentrations remain below the limit of quantification for 6 days, coinciding with persistent VRE isolation. So they switch to a continuous infusion at 2,400 milligrams per day. They achieve therapeutic levels, but then they end up with super therapeutic exposure. And they end up with adrenergic toxicity. The linezolid clearance declines from 14.6 to 16.2 liters per hour, unrelated to renal function. And they're suggesting that there's some influence of a non-linear elimination and alternate metabolic pathways. They go ahead, they drain the empyema, got to do that. They withdraw ketamine, and the PK parameters stabilize. But they do point out that this case highlights the extreme intra-individual PK variability of linezolid in critical illness. And they suggest there may have been contributing mechanisms such as an ROS-driven CYP2J2 upregulation in acute lung injury, maybe autoinhibitions of metabolite formation and drug interactions. It's really tough to draw too much because this is a single case report, but I think it does suggest that it might make sense to look a little more closely at linezolid in situations where there may be impact on CYP2J2.
I do love linezolid. But yeah, I mean, I didn't, that optic nerve disorder is something I'll have to put in my list to watch for. I was trying to look and see because I think it says what they mean by high cumulative dose. I'm going to go look at it and try to put a time frame.
It was greater than 720 milligrams per kilogram, right? So let's think about that. So you're normally giving it 600, normally giving about a gram a day, right? 70 kilogram person. So just start thinking about getting up to greater than 720 milligrams per kilogram. So it's going to be a pretty significant. And you can look at these people are in it usually for periods of time. So maybe we're thinking like folks that might end up part of a MTB treatment, something like that. Probably not our typical, 1 to 2 week for a bacteremia or something.
Yeah. Wow. That brings us to the end of this Labor Day Puscast. As always, references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher, or on YouTube where you can see us, you can subscribe, you can like us, you can ring the bell, you can leave really nice comments. We love to get your questions, comments, and paper suggestions. Keep sending them to us at puscast@microbe.tv, or you can just email me directly. I think we sort of have a small enough crowd here that most people just email me, but that's fine. You do it Puscast and we'll send it to Sara also. You could also just email her directly. But if you like what we do or just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or Parasites Without Borders at parasiteswithoutborders.com. and click on the donate button.
I'm Sara Dong. You can find me on Blue Sky at sarawindong.febralpodcast.com, or of course on the Febral Podcast.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.